Hello, Khan, am I
Yes,
audible?
sir. Yes, sir. You're audible, sir.
Sir, good evening, Ajit sir. Thanks for joining, sir.
No problem, pleasure. Absolutely.
We'll just wait for Thomas sir to join and maybe by 7 we'll start, sir.
Sure.
You want to check your slides, sir, once? Did you, Khan? Can you help, sir, with that?
Sir.
Yeah. Can I share my screen?
Yes, sir. Please share, sir. Yes, sir. Share, sir. Yes, sir. You're audible.
Can you see the slides?
Yes.
Yes, sir.
Any
Okay,
video
fine.
movie you check, sir, once? Any moving video?
Moving?
They're playing.
Oh, good. All right. So I think
Okay,
we're
sir.
okay.
Yeah. Thank you, sir.
Let's get on that. Yeah.
As others are just joining, sir, I wanted to check with you. Like last
Uh-huh.
year, we did it part of it. Which day you want to do it? Other days, I can adjust other things, sir. So I wanted to check with you both. Anyway, we can discuss later also. Or you
Okay.
want to do one day prior also is fine. Whatever you people decide.
I'll discuss with Tom and get back to you. I didn't think about it yet. So anytime.
No problem. So one request is, sir, Sipla people said last time also they'll participate. They didn't come back. If you tell the probability, other Sun,
Okay.
MQR and all are known to me, but Sipla somehow never associated with the TCT meeting before. You can just put
I'll
in a
tell
word.
them that. I'll tell them.
Basically to help in getting doctors only. We don't want their money or anything.
No, I think what we need is the crowds.
Yeah, that's why, sir. You please put in a word at least for
I'll
this
do that. Yeah,
the
no problem.
STEMI thing. They should concentrate and get people.
Sure. No issues.
Okay, sir. Thank you, sir. Shall we? Raghu is joined, I think. Can you call Thomas, sir?
Yes, I'll call him.
What is the status of this live case business, sir? Ajit, sir, what do you think? Big
I
confusion
think by
going
the
on.
time your meeting comes, it'll all be cleared. I don't think there should be an issue there. I
Some
think
judgment, June,
by
huh?
June, the judgment will come. Yeah.
Okay, sir.
Anyway, we had some 2, 3 meetings recently with no problem. We did the live cases. Nobody asked any questions.
Okay, did, sir? Okay.
Including this SHS, the what is that? Rajpal Abechan, he did a recent structural meeting. We
Okay.
did 2 live cases, no problem. I've been doing live cases for all these work. 15, 20 people come every weekend to us for IVS Society, this, that.
Yeah.
They are low-key meetings, but still nobody has any questions about that.
I think TCT India's main interest was also having good live cases from various centers. So
Yeah.
without those, I was thinking how to accommodate, whether to change the pattern or something.
Yeah, without live case is a bit boring. All this live inbox and all is a headache. Rather than
Little
that, it's
boring,
just,
sir. Many people won't be able to do it well. Like PCR example they take, but only few people like you can do it really well. But many of the novices cannot do it like a real live in a box to create interest. It becomes like lectures of one half an hour lecture. It becomes boring.
yeah, and all these 2, 3 sounds coming, he's pausing, somebody else's
Yeah,
sound coming, all confusion.
confusion. Correct. That's why I'm thinking how to do it. So little technique oriented, deep dive discussions, or I coach something like that. We'll incorporate your thinking, sir. We'll take your opinion also further.
Sure, sir, no problem.
But
Absolutely no.
more than anything, first we request you to block your dates and be available for the Hyderabad, sir, this time.
Yeah,
Yeah,
no problem. We'll be there. Absolutely will be.
right. I think our Ramakrishna is joining and Rishi Sethi also. This how the format of this is. We will be only faculty will be joining here. So rest of the program will be live streamed to the YouTube channel. Others will be given access there. Only I think Thomas sir and Rishi Sethi, the faculty are sent this link. Uh, Raghu, did you join? Khan?
I called up, sir. I think he's driving down.
Okay.
5 more minutes. He'll join, sir.
No problem. We have 5 minutes anyway, 6 minutes more. Ramakrishna is my colleague, sir, in here. He joined just.
Hey, Ramakrishna, how are you?
You're muted.
How's the election heat coming on in Hyderabad?
But now the fight is between Congress and BJP here, sir. The routine local party lost its charm. Unnecessarily, they spoiled the image in the public. Arrogance. They're
Yeah,
in.
also, yeah, it's basically the AIDMK is out of the action. It's basically DMK versus BJP. I think because of the long-standing Dravidian party issues, DMK will go through, but BJP will take some seats this time.
Okay. I think Thomas sir has also joined. Good evening, Thomas sir. You're muted, sir.
You're
Sorry,
muted.
sorry.
Okay.
Yeah, now we can hear you.
Good hear you.
Yeah.
We have 4 more minutes, sir. You want to check your slides once?
My slides are good.
Whether they're playing, you want to share and see once. It's up to you.
Can you see them?
Yeah.
I just in the middle of work. I just managed to get here in time.
Couple more angios, but I told somebody to do it.
Srinivas, how's the preparation for the meeting all going well?
Yeah, going on, sir. But confusion is like how to. That's what I was discussing with Ajit sir. What is the status of live cases? That will be known in June, I believe. Then only we'll be able to plan everything perfectly.
With all these courts, no, when it comes to finally taking up a case, they'll postpone it at the last minute.
Yeah. And other thing is regarding the STEMI portion, STEM India thing, which day you wanted to do it also. If you tell the other things, I can adjust accordingly.
Yeah. I would prefer it on a Saturday.
The second day of the meeting.
Yeah.
Is it okay, sir? Ajit sir?
Yeah, I'm fine. Absolutely.
Okay, sir. So, like, we'll mix some of the cases like last time because that is what people are also interested apart from routine lectures.
Sure.
And this sort of every month I'm doing one of it with each knowledge partner just to create some sound and buzz about the meeting. So that's the idea. Thanks for agreeing and joining. I think we'll wait for another 3 minutes and then join. The pattern is only the faculty will join in this Zoom link. Rest will be relayed through YouTube channel of TCT India. About 300-400 last month, about 300-400, 350 or so joins. So this time also around maybe little more will join. And one more, Rishi Sethi is also supposed to join, but his talk is in the end. We can start off once the time is. I checked with him. He said he's joining. So whenever you say, once it is maybe 2 minutes more.
Yeah. 2 minutes.
Khan, you are ready to stream it live on YouTube?
Yes, sir. It's live, sir.
Okay, right. Okay.
So give us a 1, 2, 3 count when you're ready. We go to share screen.
You just try once share Siska before you start. You did, no? Okay.
Yeah, I can do it again if you wish.
No videos, no, sir, in your thing. Then there's
No
no problem.
videos, no videos.
That's fine. I'll just briefly introduce for half a minute, sir. Then you, sir, and Ajit, sir, can say a few comments. Then you can start off with your lecture. Is that okay, sir?
Yeah, sounds good.
I think we'll start. Okay. Good evening, everyone. Thanks for joining, and my special thanks to Dr. Ajit sir and Dr. Thomas Alexander sir for making this possible, and also making STEMI India to be done this year also as a part of TCT India. Basically, these intro type of meetings are being planned to create awareness among the upcoming TCT India South Asia meeting, which will be July 26, 27, 28 in Hyderabad, HICC. I request all of you to block your dates, and this interesting aspect of STEMI discussions will be also part. Just now we decided probably it will be there on Saturday. We'll communicate to all of you more, and request all of you to be part of it. And concepts or important things which are likely to come up will be discussed here. Then that's how I requested Dr. Thomas Alexander sir and Dr. Ajit sir to be part of this. And then probably as the agenda is circulated already, we will have a current status of primary PCI and pharmacokinetic strategy in India with Dr. Thomas Alexander sir, and imaging highlights will be done. In role of it will be highlighted by Dr. Ajit sir. Then we'll show some interesting cases of complex coronary anatomy and how imaging made difference in young mice. With these few words, I request Thomas sir and Ajit sir. Ajit sir, you can say a few words, then hand over to Thomas. Over to you, Dr. Ajit sir.
Yeah, thanks, Srinivas, for giving us this opportunity. I think STEMI India has participated with TCT India last year, and we hope to collaborate very successfully this year. And as a startup for this association for this year, we thought this webinar will be good. So Thomas will start off first with his talk on the systems and pharmacoinvasive treatment for STEMI. Tom?
Thanks, Ajit. Thanks, Srinivas. It's great for STEMI India to be part of TCT South Asia, and I hope this collaboration will continue for the years to come. So I'm just going to share my screen, and I thought what I would do today is to talk about reperfusion strategies in India and the important role of pharmacoinvasive treatment. I might talk a little bit about practical aspects of pharmacoinvasive treatment rather than talk much about theory of pharmacoinvasive treatment, so that I think there will be a lot of discussion on this. Now, STEMI India has been a pioneer in developing systems of care in India and across low and middle income countries. And we have been in the last 8 to 10 years of the existence of STEMI India, we've been able to get conferences, bodies within the government to focus on STEMI as an area that needs attention, and not just in management, but in putting together systems so that people get early reperfusion therapy. Now, when Ajit and I started this endeavor, what really got us into this was the data that was available at that point, close to 10 years ago, about STEMI and how there was very little of focus on ensuring that reperfusion therapy was available to every citizen of this country. Now, if you look at data from across the world, and you take ACS as a group, you see that in developing countries, in India, from the CREATE registry as well as from other registries, you see that a significant larger percentage of ACS present as STEMI. And this is not what you see in the Western population. And there are various reasons that we attribute to this. But whatever the reasons, I think this is an area that needs focus. And if you look at Western data, US data, and you look at the number of STEMI per million population, varies It's about 700 or so now per million. And European data, again, varies between 700 and 1,250. But the data from India is much higher. It's about 1,500 to 2,000 MI per million. And here again, if you look at that as the number for our population, we should be receiving close to 2 to 2.6 million patients with MI yearly. And if you take the STEMI part of that as about 50 to 60%, that could add up to something like 1.2 to 1.5 million STEMI per year. Now, if you were to look at the CREATE and the Kerala ACS registry, you would be tempted to think that a substantial number of the patients with STEMI get reperfusion therapy. If you look at the data from CREATE, and this is close to 10 to 15 years old data, it's that would be about 60%, but again, this is urban data. If you take the Kerala ACS registry, again, it's between 40 to 60%, but now it's much more closer to 80%. But if you go to states that are in the north and northeast, and this is data from the Himachal Pradesh data, and you look at the reperfusion rate, it is only about 35%, and PCI in them constitutes only 0.6% of that. We looked at data from the number of doses of lytics that are being used and from the national registry. If you take the national registry, close to about 150,000 primary PCI done across the country, maybe closer between 150 to 200,000. And the number of lytic doses is about 400,000. So we totally add everything together. For the 1.2 to 1.5 million patients with STEMI, only about 40% of them would get reperfusion therapy. And this seems to be the number that the Himachal Pradesh data really shows. So Kerala and South India are probably outliers where it might be closer to 70% or even 80%. But large parts of our country do not get reperfusion therapy. And this is why a STEMI program or a STEMI network solution is required. This is a paper that we published in Asia Intervention, where we looked at the various factors that we need to put in place when we try to develop a STEMI system of care. I won't go into the details of these, but clearly when you run a program, as we've done in some of the states, Tamil Nadu, Andhra is starting their program, Karnataka has a program, we started some work in Punjab, Jharkhand, and in many of the countries, in some of the countries in Africa, in Egypt, in South Africa, in Sudan. We're now starting in Tanzania and Uganda, and we've started in Azerbaijan. So there are countries, and most of them have utilized the models that we have developed, and the learnings from them is what has helped us to help these governments to run these programs. Now, I think it's important for us to understand that when we initially started our program in Tamil Nadu, we looked at the hub and spoke model and combining pharmacoinvasive with primary PCI. But as we started our programs in other parts of the country, particularly in rural states like Jharkhand, we could quickly realize that it's not possible to run a pharmacoinvasive primary PCI model alone, and we need to look at different models. And this is where the STEMI India model, which is now called the global model for low and middle income countries by Stent Save a Life, EuroPCR, where we looked at 3 different models. And this is model 1 is when a district has no tertiary hospitals. We look at purely moving the population from no reperfusion to some form of reperfusion. And there is an element of remote diagnosis. We now have developed capabilities for tele-ECG service, which we link to the ECG machines that are located within these small hospitals, so that we sort of handhold them to confirm the diagnosis of STEMI, so that thrombolytics are used. Once a thrombolysis is done, a patient is shifted to a tertiary care center only if they have either cardiogenic shock, failed thrombolysis, or a hemodynamic or a electrical instability. Model 2 is the model that we ran in Tamil Nadu, is now being run in the state of Tamil Nadu, is being run in Andhra Pradesh and in Karnataka, where we link different types of hospitals, the spokes, where thrombolysis is done, and then move to the hub for pharmacoinvasive treatment, and those that come to the hub get primary PCI. The third model, and this is the model that we've now running in Cairo, it's an urban model. So when there are hospitals located very close to each other where primary PCI is feasible, we do not thrombolyze the patient outside. We only move them to the closest hub hospital so the primary PCI is done. So these spokes in Model 3 is only used for diagnosis and giving emergency medication. Now, clearly, in a country like ours, we just saw that the large number of reperfusion therapy is almost 3-to-1 is by thrombolysis. A small number of them would get converted into pharmacoinvasive, and probably the more rural parts of our country will have only standalone thrombolysis. I think when we talk about pharmacoinvasive, and this is a paper that both Ajit and I, it was published in Cardiovascular Interventions. The sweet spot between pharmacoinvasive and primary PCI is about 120-minute delay. So, and you will see this in multiple guidelines. If there is a delay that is expected of greater than 2 hours for getting a patient to primary PCI, then it's better to thrombolyze them and go the pharmacoinvasive route rather than trying to take them to a hospital and get further delayed, because that is where the equipoise is. So remember this. Even within our hospitals, if our cath labs are occupied with, say, a TAVR or a long complex coronary angioplasty, you have a patient in the emergency room, and it doesn't look like this patient will get to primary PCI within 2 hours, even within hospitals with capabilities for primary PCI, you will be doing a greater service to your patient if you thrombolyze the patient and then move the patient for pharmacoinvasive. So I'm just going to talk about 8 points, 8 to 10 slides from now, just looking at some of the important aspects of pharmacoinvasive therapy. So when should you think of pharmacoinvasive strategy? So first of all, I think there should be no absolute contraindication to fibrinolytic, or these are patients with no high risk for bleeding. So if any of these are there, clearly they cannot go through the pharmacoinvasive. The lower risk patients, those without cardiogenic shock, they could go through either. So if you have delays, these are patients that can go for the pharmacoinvasive. When you have a diagnostic dilemma and you're not sure, is this an acute MI or is it not? Again, this might be a situation where you might favor taking this patient directly to the cath lab rather than doing a pharmacoinvasive. If you have a patient presence to a non-PCI hospital, clearly without contraindication for fibrinolysis, then you can think of pharmacoinvasive. Again, when there's delay in the primary PCI, again, think of pharmacoinvasive. And when you have a patient presenting very early, and I say 3 hours here, but really, if you have a patient within 1 hour of chest pain, the number of aborted MIs is close to about 20 to 25% if they're thrombolyzed immediately. Clearly, there will be a lag in time of moving a patient to a cath lab as compared to just using one of the lytics, especially if it's tenecteplase, which is just going to give a bolus. And if it's within the first hour, remember that about 20 to 25% would have an aborted MI, and that would be the best sort of scenario rather than even taking this patient to the cath lab. Now, is pharmacoinvasive better than standalone fibrinolysis and as good as primary PCI? And this is a question that is often asked to us. Why should we do pharmacoinvasive when we give a thrombolytic, the patient's STs have settled, patient looks good, should we not wait, exercise this patient, and then decide whether to take the patient to the cath lab? And this is a network analysis. Again, this is from the Journal of American Heart Association. Ajit, as you can see, is part of this paper from Brahmaji Nalamuthu and group, who've looked at various strategies. So they looked at thrombolytic versus primary PCI 14 studies, thrombolytic versus facilitated PCI 3 studies, facilitated PCI versus primary PCI 7 studies, pharmacoinvasive versus plain standalone thrombolytic 6 studies, pharmacoinvasive versus primary PCI 5 studies. So this constitutes virtually every study that has been done to compare one strategy with the other. I'm just going to show you some of the data here. If you take fibrinolytic therapy as the reference and you compare it with primary PCI, whether you look at death, you look at reinfarction, you look at stroke, you can see that primary PCI is clearly superior. So there's no doubt in any of our minds that primary PCI is the best form of reperfusion, and there is no significant increase in bleeding rates as compared to this. If you take the pharmacoinvasive approach, clearly it's the reinfarction rates which are significantly lower when you take fibrinolytic versus pharmacoinvasive therapy. Now, if you look at it in a different way, and this is the Bayesian model to estimate the probability of risk, and you take primary PCI as those with the lowest risk, you can see with fibrinolytic therapy, the risk of death is 69%, with pharmacoinvasive, it's only 6%. Reinfarction is 99% versus 0.1%. Stroke is 72%. This is 11.1. So clearly there is an increase in stroke as compared to primary PCI, but much less than that with fibrinolytic. Major bleeding is a concern. And again, we look at strategies to reduce bleeding, but especially in pharmacoinvasive, because you have an invasive part to this pharmacoinvasive, and that could be a problem. Another question that's commonly asked is most of the studies, and if you look at the Western studies, it's the third generation lytics that have been used in pharmacoinvasive. Can streptokinase, and which is the commonly used thrombolytic agent in our country and most of the low and middle income countries, can that be used? Now, if you look at the data that we had from the Tamil Nadu study, you can see that 96% of our patients had streptokinase that was used. And this is a paper that we published in the American Journal of Cardiovascular Drugs. This is a subgroup analysis of our patients where we did a propensity analysis. We looked at all the multivariates, confounders, and then we looked at the numbers. We got about 400 each, those who went for primary PCI and pharmacoinvasive with streptokinase. And look at the data. Whether you look at the 1 month mortality, 2%, 2.1%, at 1 year, 8.5, 8.1%, 9.8%, 8.8%, with no significant difference in terms of bleeding risk. So if you look at the streptokinase data, this is the only data available across the world. And this is the data from our study. And we were able to show that streptokinase did as well in the pharmacoinvasive subgroup as tenecteplase or reteplase in the other studies that came from the Western. What is the best timing to use? And we all know that streptokinase is a non-fibrin specific, it's not a fibrin specific lytic agent, and therefore there is a certain amount of fibrinolysis that is across, and therefore when you use different ways of doing an invasive procedure, is there an increased bleeding risk, especially if you're giving additional heparin in the cath lab? Now, one of the strategies that we used in our program is to delay the pharmacoinvasive treatment. Now, if you look at the Western data, and these are the various studies, the STREAM, the STEPI, the early Mayo, Ottawa registry, you'll see that it's all in the 8, 6, 8, not beyond 12 hours that you're seeing that these patients were taken to the cath lab. What we did with streptokinase, and this is because of this strategy, and we know that pharmacoinvasive is 2 to 24 hours after thrombolysis, we used 17 hours, and a little on the latter part of that time frame is where we took these patients, and we showed that there was no increase. We did not have an increased bleeding risk in these patients. And maybe if streptokinase is the lytic that is being used for pharmacoinvasive, it makes sense to take them to the cath lab a little later than you would with tenecteplase or reticlase. What about the lytic dose in the elderly? And this is again, I'm going to, this is both the stream and the stream 2 data. Now, just to refresh your memory, the stream used a full dose tenecteplase in the pharmacoinvasive arm. These are patients within 3 hours of chest pain, pharmacoinvasive when the delay was going to be more than 1 hour, and versus primary PCI. But halfway through the after 1/5 of the randomization took place, there was an increased bleeding risk in the elderly, and therefore they switched to a half-dose tenecteplase in the stream study. Stream 2, which has just been published, this is the patients above 60 years, used half-dose tenecteplase. And what they found was that, this is in the elderly patients again, the pharmacoinvasive group, that between stream 1 and stream 2, the efficacy was absolutely almost the same in terms of MACE, and the bleeding risks were also on the lower side with half-dose tenecteplase. So in the elderly, if you're thinking of pharmacoinvasive treatment, I think you can get as good a result with half-dose tenecteplase as you would with full dose, with less of bleeding risk. Now, reducing the bleeding risk, and another strategy, of course, is vascular access. And if you look at this, our own data, radial access is the one that we use. So using half-dose tenecteplase, using the radial route, and if you're using streptokinase, taking the patient to the cath lab a little later than the early shoot to the cath lab may make the bleeding risk less. What about the DAPT? Now, we all know that in the thrombolytic subset, we use, whether it's streptokinase or tenecteplase, clopidogrel and aspirin is given to improve the reperfusion rates and reduce the acute reocclusion rates. Now, if this patient then goes to the cath lab, what is the strategy that we use? Now, many of us would use ticagrelor in these patients, and this is from the TREAT study. And here it's more a question of safety. In the TREAT study, patients who were thrombolized and had clopidogrel given were given an additional dose, loading dose of ticagrelor, or another dose of clopidogrel, 300 milligrams. So say 600 versus ticagrelor 180, and this was given about 10 to 11 hours after thrombolysis. And there was no increased bleeding risk seen in them. In terms of efficacy, that study was too small to look for efficacy. But in terms of risks of bleeding, if you were to take this patient about 8 to 10 hours after thrombolysis, and even if they have clopidogrel on board, 300 milligrams, shifting them to ticagrelor in the cath lab before doing primary PCI does not have a downside in terms of bleeding. We looked at our own data, the newer antiplatelets versus clopidogrel in the cath lab. And what we found is that if you look at mortality, and this is efficacy we're talking about, there seem to be definitely, in terms of mortality, an advantage in shifting to the newer, to the more effective anticoagulants, that's ticagrelor. There was a period we used prasugrel. This is before ticagrelor came onto the market, but even with the use of prasugrel, we found that doubling the dose of clopidogrel versus using the newer either ticagrelor or nowadays we don't use prasugrel at all, really had a significant reduction in mortality. So in terms of efficacy and safety, it makes sense to move to ticagrelor once the patient is moved to the cath lab. Finally, does setting up a system of care improve results? And this is again data, our own data. By setting up a system of care, we were able to reduce the time to first medical contact to ECG, lysis to angiogram, and the total ischemia time. And what we were able to show as a result of that improvement is that our infarct-related artery patency was better, the thrombus burden was lower, readmission rates were less, and TVR at 1 year was much better. So also if you look at the TIMI flow. So finally, I think what is the future of pharmacokinesis? This is a paper or an editorial that Ajit and I authored in the latest issue of Circulation. There's no doubt that timely PCI, primary PCI, is the best strategy. And if you look at stream 2 and stream data, this is the best data. But pharmacoinvasive, when delays are expected, pharmacoinvasive is a very effective strategy. But there are concerns about increase in intracerebral hemorrhage and failed perfusion. But in a country like ours, as we transition from no reperfusion to standalone fibrinolysis to pharmacoinvasive, and finally on to primary PCI, I think pharmacoinvasive strategy is something that we need to be aware of. Thank you for your attention.
Thank you, Dr. Thomas, sir, for highlighting the importance of pharmacokinetic strategy in our country. But the systems of care, what I find nowadays is when you are involving all the hospitals, some of these government, if I'm permitted to say, some of these governmental medical college type of hospitals, at least in Telangana, I can say that were involved. They're also doing only lysis, where they're actually supposed to doing PCI. So that's how in our state we got all the lysis data rather than a mixture of pharmacoinvasive data. Anyway, there may be some differences, but ideally speaking, all those selected for PCIs are not doing primary PCIs. There also lysis is being done, and elective leave after 5 days or so. Sometimes angiograms are done, or sometimes they go to other places. Other important thing what you highlighted is only 10% of patients are getting into primary PCI and 30% revascularization. But still, there is more necessity to leave lysis for more number of patients. Still, about 60% of MIs are not being given any of the therapy. And very relevant for our country, I think you highlighted ticagrelor nowadays, I think can be given as initial antiplatelet without worry. Though prasugrel, we are worried not to give with lysis therapy. Those are some of the points which are relevant. I think we can have some discussion at the end because we are slightly over board on time. Anything, Ajit sir, you want to say any comments about this? Otherwise, you can go on to your lecture of
I think
imaging.
we'll go on to our lectures, my lectures at an interest plan. Yeah.
So many people request to tell us they are interested to do OCTs, but the flows are not there. So what are the tips and tricks to do proper OCT by small predilatations and things like that you can cover, sir, because the general audience too in this. Thank you.
Okay, can you see my slides?
Yes, sir, we can see it.
Okay. And so should all MI patients be stented or not? And if so, how does imaging help us? So if you look at acute coronary syndrome lesion classification, you have three great groups of patients who come with ACS. One is a disrupted fibrous cap, where there is an underlying lipid plaque, which is a plaque rupture. That's how that looks like. So that's TCFA, which is broken, and the plaque has been emptied into the cavity. Then there's an underlying plaque with calcium, which is basically four types: the protruding nodular calcium with an attached thrombus, sometimes superficial calcium, sometimes plate calciums, as we say, and eruptive nodules. And in short, if you look at an OCT, this is how the nodule will look like. It's like a protruding sort of a mountain inside the coronary artery. The third group is when there's the intact fibrous cap, where there's thrombus, but the cap or the plaque is there, but the cap is intact. There is also a scenario where you see thrombus, but you can't see the underlying plaque or you can't be sure it is there or not. And this is known as an erosion. So there is an intact cap. So here you can see the cap is intact and there is stuff protruding out, which is thrombus. And this is a clear-cut definitive erosion. And then there are groups which are uncommon, but you can see them off and on, especially in women. And here is something called as a SCAD with a large intramural blood, which is called as an intramural hematoma. So these are the four major areas where we need to do. So this is a patient who presents with an anterior wall non-STEMI, and you can see in this angiogram and on the OCT very clearly that what we showed you as a first case, that there is a fibrous cap which is ruptured and the cavity has, all the plaque has been emptied. Very, very clear seen here, and this is a longitudinal picture of the OCT, and you can see. So what is this? This is plaque rupture. No confusion here. How do you fix this vessel? because there's a large plaque rupture with a luminal compromise. You directly stent the patient, and that's the end of the story for this patient. Here's another patient who comes in. He's anterior wall MI lysed, sent to a hospital. The angiogram sees, you can see some fuzzy structure here in the proximal LAD. You can see on the OCT very clearly there's thrombus here, and behind this I can't see the plaque, but clearly there is no rupture or anything of that sort. The lumen is pretty big. So what is your diagnosis? This is an erosion, and here you can see in this loop that you can see backside of the artery is clear. So basically this is a definitive erosion. Here's another patient, comes with non-STEMI. Again, you can see in the proximal LAD something very hazy. And here you can see again a large clot which is coming. You can see the longitudinal view. The backside of the clot is not seen. You can see a sort of an attenuated structure. It could be attenuated plaque here, but clearly I can't see whether the backside of the plaque. So clearly, this what is this? This is a probable erosion. Now, 6 weeks later, this patient was treated with antiplatelets and heparin and brought back. And you can see very, very clearly that we have not put a stent or anything because the lumen was good. Sorry. What you can see very clearly in this picture that very nicely the plaque has, the thrombus has disappeared. And clearly all you can see is a residual thin strip of some organized thrombus. So patient did not have a stent. And in erosion, it is better not to stent these patients. Here's a right coronary artery, which you can see clearly. There's some haziness. It comes with acute coronary syndromes with enzyme rise. And you can see in here, very, very nicely, there is some stuff which is protruding into. This is not thrombus. This is a calcified nodule, which is clearly protruding into the lumen and is creating the rupture of the calcific nodule. There are two types, eruptive and non-eruptive calcific nodules. And you can see on the longitudinal again this. These sort of patients you should not go and directly stent these patients because you will get into trouble. The stent will not open up in these areas. So you need to be careful what you do for these patients. So this is a classic calcified nodule for this patient. This is a 50-year-old lady who comes with a troponin elevation. Normally, in these patients, we nowadays do only a CT. In this patient, patient had an imaging procedure. You have to be very careful. No CT. This is a SCAD. You can see a clear-cut flap, which is dissecting through. In the longitudinal, you can see the whole flap and the whole blood behind that. And this is a typical SCAD on an IVUS. Don't do OCT in these patients because this will increase the SCAD in these patients by injecting under pressure. Most of these patients, if their lumens are good, like this patient is, do not need anything but medical treatment. And it's better not to stent these patients because they have bad outcomes. So this is a spontaneous coronary artery dissection. Here's an inferior wall MI non-STEMI patient who came to us. My registrar called me and said that looks like thrombus. So this should we go ahead and do the procedure? So I said, okay, let's do an imaging. And this is what we call as organized thrombus. This is a lotus stem appearance, which is very, very clear of organized thrombus. So this patient had possibly an MI some time ago, and the thrombus had organized very, very nicely. Now this patient, unless he has pain, you should be very careful in fiddling around with these micro channels because in trying to wire it, sometimes you can close the vessel, and most of the times we treat them medically in this situation. It's a typical lotus stem appearance which you can see on an OCT picture. This is a very young guy who came with again a non-STEMI with a strong family history, strong smoker. And you can see in this angiogram, and what's this angiogram? Again, there's some sort of a funny lesion here, but you can see that the lesion is proximal to the diagonal, closer to the left main, and this is a good lumen on this patient. So we elected to treat this patient medically because the lumen looked nice, flows are T3 flow. So we diagnosed this without an imaging at that point of time as possibly a plaque erosion and thrombus. Put him on dual antiplatelet therapy, low molecular. He was continued on medical management. 2 years later, the gentleman now comes with again ACS. And now you can see that the lesion is not only in the proximal prior to the septal, it's in fact distal. And this is very important to understand. Because if you had gone and put a stent there, you would have got into a problem because this patient has got now a lesion in the next, beyond the septum. He was planned for antiplatelet and anticoagulant. We gave it for 2 days, and then we had a routine check, which we do for all patients who are young, where we suspect plaque erosion, which includes a phospholipid, lupus anticoagulant, lipoprotein A. And in this patient, yes, the LP little a was little high, and the homocysteine was high, but otherwise most of the anticoagulant screening and other things was negative. So post anticoagulation after 2 days of low molecular heparin and dual antiplatelet, he was taken up, and you can see again a very nice OCT, which shows again thrombus here sitting here, this clear-cut plaque erosion. But you can see the lumen 6.87 at the minimal area. You don't need to stem this patient. You can treat these patients with, nowadays we put them on a NOAC and single antiplatelet because there's a lot of thrombus and ectasia in these vessels, and keep them on long term. Most important thing is to stop smoking, and he had, folic acid for his homocysteine levels. Now, this is a 33-year-old, all young patients. You can see maybe it's a little overlap with the next, but this is a very interesting group of patients. His troponin went up, he had chest pain. We did an angiogram next day morning, and you can see a very, very hazy lesion. Remember, don't go and stent this directly. Many people have the itch to stent these patients. And this can create a huge amount of clot to go down, and then you'll be struggling with no reflow. Flows are good. All you treat this is treat them with 2-3 receptor block if they're not on antiplatelet. If they're on and dual antiplatelet and enoxaparin. And what we did is we looked at the OCT after 48 hours, and clearly again the same story. Thrombus here, but lumen is good. We don't need to fix. Lumen area is 9 millimeters squares. We can just leave this patient on anticoagulant and aspirin. So this patient was put on warfarin and antiplatelet therapy for 1 month, and then single antiplatelet and warfarin after that. We brought this patient back after 1.5 months, and you can see again the angiogram looks better. And really, if you look at the OCT, it doesn't look as if something happened to this patient. Everything is cleared out, and it is unnecessary to stent these patients. There's a pre-3D reconstruction of OCT pre and post. The entire clot has disappeared from the artery. So basically, in such situations, don't put a stent. That's the story which we have. Case 9, again, young guy, who came with ST elevation in inferior lateral leads with an anterolateral MI. And you can see in this angiogram that this patient has got a lesion in the distal LAD. You can see it here. Now, what is this? How does this work? So what we do in this situation is we thrombolize with reticulase into a custom-based infusion. We used to have Clearway before. We now give this here, and what is interesting to see is that you give this infusion distally, and most importantly, what you should watch here is the proximal LAD. Proximal LAD is a bit hazy here. So what this diagnosis is a ruptured plaque proximal LAD with a thrombus being embolized distally. And this is not the lesion. The lesion is here. The lesion from here formed a thrombus and went down here. So we gave intracoronary lysis and was kept on 2B3A for 24 hours, brought the patient back. And you can see very, very clearly that the artery looks distally absolutely clear. And there's some disease here, which we did an OCT for, which we found that the lumen was good enough. It was just a small rupture plaque there with good lumen. Again, we treated medically. We didn't put any stent there. So remember, if you have a lumen which is large, whether there is erosion or the small rupture, we don't need to stent these patients. Just treat them with antiplatelet statins. And if there's a large thrombus or if there's a lactatic vessel, maybe an anticoagulant. I think this may be the last patient, which I'll quickly tell you. This is a patient who had this sort of a disease who came with ACS. And you can see the LAD seems to be the culprit, which has disease there. But it's not a flow-limiting vessel. So we do an OCT. And again, you can see thrombus here very nicely on the longitudinal thing. A lot of thrombus here. And lumen, which is good. Patient was put on warfarin for 6 weeks. I brought the patient up at the 3-month follow-up for an angiogram. And you can see that things have cleared here very nicely. So what we do here is we check, because there's a doubt whether we need to fix this or not. The acute phase is over, so you can do a functional test. You can see the LED IFR is 0.99. The FFR is 0.79, which is borderline FFR and good IFR. Left LED does not need anything. You can see a nasty looking lesion in the circ, but the most important thing is to do test properly. And the IFR is 0.97, the FFR is 0.84. This patient is now 5-year follow-up in medical management with no events. So basically, you can leave these patients alone rather than stenting everything and getting into trouble. So I think that what is important to conclude is that there are two studies, the erosion, which show that if you do OCT and show that this is erosion, between, if you follow them up, these patients can be followed with aspirin and decarol without stenting, and they remain free of major cardiovascular events. And the erosion 3, which was a Chinese study, which was a multi-center randomized of OCT guided reperfusion in Stemi with early, showed that if you received OCT guided reperfusion as compared to angio guided perfusion in 110 patients, your event rates were no different, and you unnecessarily put in more stents for these patients. So we can use imaging to guide decision making, optimizing the reperfusion study, but we need large randomized studies with imaging to really show whether which lesions we can completely leave, which lesions we need close follow-up, and which lesions you need to stent. Thank you very much.
Thank you, Dr. Ajit sir, for showing interesting cases and highlighting how to manage these cases. This is what is another advantage of pharmacolysis, pharmaco-invasive strategy, I feel. Thomas sir, you're mentioning. So we did have some data about 150 patients before, out of which about 30 patients we could avoid stenting totally because they had recanalized vessel, though imaging was not done in them. So some of these, when you take up for the procedures, then stents may not be required. So young patients will avoid putting stents. Many of the times the clinicians get doubts, sir, because of thrombus burden. If it's in within a 6 hours period, you decide for lysis, or later you give only GP2B3 receptor blocker. How do you decide on lysis versus GP2B3 receptor blocker?
So when I see intracoronary thrombus, my decisions are a few. Is this red thrombus? Is it white thrombus? Number one. Is it large thrombus? Is it less thrombus? And is it ectatic vessels? And the second most important thing is what is the lumen of the vessel? If you have, small lumens and low flows, even if the thrombus is small, you will get into trouble because the artery will completely close. So we need to decide these things. If the patient is naive to antithrombotic therapy with antiplatelet therapy, it's the first event, and he comes and it is just white thrombus or small red thrombus and, lumen is good, I just put them on dual antiplatelet therapy, especially with tecatrolol. We can act in 1 hour, it can act, so there's no big problem there. Previously, we used to be 3 receptor blockers when you were using aspirin and clopidogrel in these patients. But you have a large thrombus inside the coronary, and it is really obstructing flow. Intracoronary lysis is a very good way. We've been always wary of this, but I'm very, generous in using intracoronary lysis because it's a large thrombus in these patients. Finally, on the follow-up, that's not very clear what we should do. But I think that if there is no stent in the patient, I think the sensible approach would be to use a single antiplatelets and one anticoagulant. What that anticoagulant could be warfarin or Novax. There's no data with either, but I could suggest that. If there is a stent, obviously you need dual antiplatelet therapy in that patient, and the anticoagulant usage could be a little, if there's a large clot apart from putting a stent, or the patient has some other reason like atrial fibrillation, maybe triple therapy for 1 month and then reduce it after that. So it's a little not clear what we should do in terms of anticoagulants, but in terms of antiplatelets, I'm more or less clear what.
Those of intracoronary lytic therapies, tenecteplase, how much you recommend to be given intracoronary?
So we can use either retiplase or tenecteplase. Usually with retiplase, I use 5 milligram. In tenecteplase, we can use boluses. Some people use partly bolus 5 milligram intracoronary and the rest intravenous. But I think that I use it bolus and just watch and see, and if things get better, then stop there.
Thank you. Dr. Ishi, good evening. You joined little late.
Srinivasan,
Any questions?
just one
sir,
point.
go. Yeah, go ahead.
Yeah, I think I've used a fair bit of streptokinase intracoronary. So what I would use is 250,000 units of streptokinase intracoronary, usually through a catheter called Amicat. I don't know if you've used it. It's a perfusion catheter with multiple perfusion holes. It's like an aspiration catheter, but with multiple holes in that. So I just take it through the vessel and infuse the streptokinase directly into the thrombus. And there's close to about 25 patients that I've used this in patients with very large thrombus load.
Sometimes you use the same export catheter to give the drug also when you don't have that type of catheter. I think Rishi, you want to say anything in this talks? We'll go to
So,
next.
so on this issue, forgive my naivety, but I generally don't use intracoronary streptokinase or any thrombolytic for that matter. What I feel is that if you have taken about a significant chunk of thrombus out and establish the flow, my personal philosophy is bring them back after any time about like 3 to 7 days, and the flow itself would act as the best anticoagulant. And many times we'll see when we do a deferred kind of strategy, the flow is impeccably clean. So I feel that flow, establishing the flow and leaving a little bit of thrombus there, and then bring the patient later for deferred strategy, probably that is what our default strategy in our department is.
Okay, thank you. I think they were talking about TME 0 and one type of flow where if minimal flow, they would take the help of lysis. I think with this now I request my colleague Dr. Ramakrishna to present two cases where we thought one can be erosion where we left with lysis, other was a dissected plaque where we stented. I think he has one or two cases to show. Over to you, Ramakrishna, to present a case.
Good
Sir
evening,
has
sir.
shown many cases already anyway.
Yeah,
Over to you.
many cases are shown by Dr. Ajit sir only. I'll show you two cases in this.
Make it full screen.
Yeah.
Right. No.
So this 31-year-old male is a smoker. He presented with chest pain after gym, and he came to hospital. By the time pain has almost subsided, ECG showing subtle ST elevations in the anterolateral leads. So echo showing RWM and distal IVS, and troponins were elevated. So he was given antiplatelets. This was his first ECG. You can see there is subtle elevation in the V5, V6, and lead 1 AVL. And this was his angiogram and the presentation to hospital. So his RCA was absolutely unremarkable. You can see his LAD. There is a large thrombus in the proximal LAD with some amount of bridging and distal embolization of the thrombus in the distal part of LAD. So at this stage, we gave some the Terif-1 and heparin, low molecular weight heparin for 3 days, and he was okay in the hospital, and ECG showing subtle changes in the anterior leads. So with the biphasic T waves in the anterior leads, V3 to V6. So after, we taken for check angiogram after 3 days. So this was again there is a large amount of thrombus in the proximal LAD, but flow is almost TME3 flow with some amount of recanalization of the distal LAD thrombus. So what we did was we did the OCT in this patient after stabilization. This was his OCT image because there is some blood spill in the distal part. So you can see large amount of thrombus. This is a normal segment in the mid portion of middle LAD, and this was again you can see large amount of red thrombus without any distinction of underlying endothelium. So in the proximal portion, there is some discontinuity of the endothelium, but it's mostly probably plaque rupture or plaque erosion. So you can see, as Ajit sir already said, see it can be red thrombus with high backscatter and high attenuation, or it can be white thrombus. You can able to see the background, and recanalized thrombus as sir has shown in the live cases and spontaneous coronary dissection. So in this patient, there is some amount of disruption in the endothelium in the proximal portion. So we put a stent in this patient. This was 3.5 into 28 stent. And after stenting, you can see the thrombus was plastered into the wall. And post PCA, this OCT is showing there is still some amount of thrombus protruding across the stent studs with the good opposition of the stent. Here you can see there is still some amount of thrombus protruding across the stented segment. So we achieved a good result with good hemodynamics. The patient was discharged on day 5, good follow-up, and no events since almost 3 years. So this was his final ECG. So this another young male, 26 years, no comorbidities, chest pain since 11 hours, ECG showing anterior wall MI, and 2D echo with the moderate LV dysfunction and LAD territory hypokinesia. This was is a 26-year-old. So you can see a large amount of thrombus from the osteoproximal LAD with the left dominant circulation, with the large ramus rising just at the ostium of the LAD with the thrombus. So at this stage, we stopped and we gave thrombolysis for this patient, followed by heparin infusion. So this was his other angle with a large amount of thrombus in the proximal LAD with the TME1 flow. This was his RCA. So after 48 hours, we again taken for check angiogram. So you can see the complete recanalization of the thrombus after giving thrombolytic therapy with still some amount of lesion and thrombus in the proximal part of LAD. So we did OCT for this patient. So still there is a large amount of thrombus in the distal portion of the LAD with TME2 flow. So this was his OCT imaging. So you can see the distal portion is clear. The proximal LAD, there is some amount of thrombus, but we could able to see the underlying intact endothelial layer. It's a blood spill, I think. So in this OCT imaging, you can see the red thrombus with the underlying endothelium. This most possibly the plaque erosion. So we left this patient without stenting. So this another 30-year-old male with the anterior wall MI. We can see there is some white thrombus in the proximal portion of LAD. So this is another OCT imaging for this young patient. The good luminal area even at the thrombus site. So you can see the thrombus with the intact endothelium. So we left this patient without stenting. He is doing good. So this another 24-year-old male with chest pain. So he presented with acute inferior wall MI. We did thrombosuction for this patient, and we achieved a good flow in the TME3 flow in the distal LAD. We didn't do imaging in this patient. We left this patient without doing anything. So he was doing good. So this already Ajit sir explained the plaque rupture or plaque erosion, definite or probable plaque erosion. You can leave the patient without stenting. If it is a plaque rupture, you need to stent the patient. Thank you.
Thank you, Ramakrishna, for showing interesting cases. Other advantage, Ajit sir, is by this, when the thrombus is very proximal where you have to put a stent, then you will be putting across LCX or left mid LAD, that sort of things in young patient looks very bad for us. So that's where I call Tanictibla is a great rescuer in cath lab. Even some patients, we do radial sheets, so we have instances where we have put this back and gave Tanictibla and everything, artery, everything cleared up later when we brought them for repeat studies. So that is another advantage of this, where you unnecessary stenting across the left main, across LCX could be avoided in some patients like that. I think each of us have such experiences like that. I think we are running slightly behind. We now go on to Rishi's talk, where STEMI with complex coronary anatomy. We have recent data which has come up with full reverse studies again showing some difference of outcomes with FFR usage in complex coronary anatomy. Let us hear more about it from Dr. Rishi. Over to you, Rishi.
Thank you, Dr. Srinivas. Thank you for inviting me today. A joint session between Fact Foundation and Stemi India, both inspirational organization. It's been a pleasure to work with all of you in past. So today I'll just show you a bouquet of cases for complex anatomy when we are dealing with STEMI PCI, both as primary PCI as well as pharmacoinvasive. And I've chosen 4 scenarios of high thrombotic burden, difficult stent deliveries, post-radiation, post-Lima interventions, and so on and so forth, presenting as acute myocardial infarctions. So we were discussing this, and this is something that we face most commonly. So I picked up heavy thrombus burden and ectasia situations. The main concern here has already been discussed in the session is of no reflow. It happens because of microvasculature being compromised, loss of vasoreactivity and an ectatic vessel, and heavy thrombus burden. So this was a case we did a long time back, and this remains a teaching case for me, and heavily ectatic, heavily thrombus burden RCA presenting as inferior wall myocardial infarction. And when we had established the flow with thrombus aspiration, we were getting a picture like this. So we are getting a lesion, we are getting a sort of a slow flow phenomena, and there is a big debate in the cath lab whether we should be stenting this lesion or not stenting this lesion. But finally, as in the reflex scenario, a stent was placed, and we saw a catastrophe happening after placing a 4 or 15 stent. A catastrophe of no reflow happened, and despite whatever we did, of all the intervention that we could do with repeat thrombus aspiration, adenosine, calcium channel blockers, we could not restore the flow. And in that gush of things, the hydrophilic wire perforated the distal segment, and catastrophe happened. So this remains a learning case for me that, once you have established the flow, we should be very, very careful, especially in cases of heavy thrombus burden, ectatic arteries, whether we should proceed with the stenting, if at all, or we should bring them for the patient to a deferred stenting kind of strategy, and what should be done when. It remains controversial, but we burnt our hand in this particular case. So one thing that we learned that there are angiographic predictors of no reflow also, and there are angiographic thrombus burden, which linear dimensions greater than 3 times of reference lumen diameters, reference IRA of greater than 4 millimeters, abrupt cutoff patterns, presence of accumulated thrombus proximal to the occlusion, and distal floating thrombus distal to the occlusion, persistence of dye stains. Almost all were present in this scenario. We could have anticipated a no reflow happening, which we did not, and it ended in catastrophe. So similarly, this case, if presenting as inferior wall myocardial infarction, you have heavily ectatic RCA, there's an abrupt cutoff of PLV. We must decide that if we just, we can just pass the wire across, establish some flow, and leave this vessel without stenting, it would probably do the patient more good than stenting it. So again, this is sometimes a couple of learning points I want to discuss here is this was a case. He was a post-CABG case, Lima. He presented with anterior wall myocardial infarction with a window period of 4 hours, taken up for primary PCI. And when we are proceeding for Lima interventions in STEMI situation, the choice of catheter and the access here is right radial for us. We feel that it gives us a much better control of access in terms of Lima engagement and deep throating sometimes when it is required, or it also leads to lesser bleeding complication. So in this particular case, the Lima LED anastomosis was abruptly cut off, and we could manage to engage, cross it with the wire, and we could realize that there was a very tight lesion at the junction of at the anastomotic site. And another learning point here is that whenever we have be it STEMI or other STEMI, if you have an anastomotic site lesion that is usually very fibrotic, so even after dilating with high pressure balloon dilatation, one might require something like a cutting balloon inflation to make that segment free, followed by stent placement from the LAD going across the anastomotic site up to the proximal and mid segment of the Lima, and we could salvage the situation with a decent flow. So that is another thing that this is a very interesting case. I was on duty, a very privileged patient presented with anterior wall myocardial infarction. The lady had a history of left breast malignancy and was post-radiation, chemoradiation, and we could find it very difficult to engage the left main ostium. The patient was becoming hypertensive. She was giving in the cardiac shock, but we were finding it increasingly difficult to engage the left main ostium. Finally, we could do it with an Emplatz catheter. It was a tight ostial stenosis, quite peculiar with the radiation stenosis, associated stenosis. And the patient, we could engage it with Emplatz. We saw pure osteoproximal lesion in the left main. We could engage it with an Emplatz, pass the wire across, did some high pressure balloon dilatation. Another point is that, again, these radiation-induced osteal lesions are heavily fibrotic. So it again required us the use of cutting balloons. And as you can see, the patient went into shock and we had to use IUBP in this particular patient also. And finally, we could stent it from the left main ostium according to the proximal LAD and could get respectable flow and could salvage the patient. So this is another very interesting case. It was a 72-year-old gentleman with history of classical angina, purely intractable angina for some time, now presented with inferior wall myocardial infarction with complete heart block. Thrombolysis was done and the patient was taken up for pharmacoinvasive strategies, and the fellow on duty at that point of time thought this lesion to be thrombus. He tried to do some thrombus aspiration, was not successful. Even a 1.5 balloon could not cross, and then we realized it was a huge chunk of thrombus sitting. And sometimes we have to remember that when we are dealing with STEMI situation, they may also be on critical calcified lesions. So we have to be prepared for all sorts of eventualities that keep on cropping in front of us. And a 1.5 balloon would not cross. There was no other option. We had to change the wire, do a rotablation, and the stent would not cross. The Zions 3.528 would not cross. The proximal lesion also. Ultimately, the patient was going down. We had to place the first stent in the proximal ostial RCA, and then we could find it very difficult to cross the second stent now, all through the first stent. We post-dilated this lesion again with a 3.5 balloon, passed the second wire, a buddy wire, post-dilated the entire stent so as to facilitate the passage of the second distal stent. And this was something very interesting that we did here. It was the stent was not crossing, so we took the help of this balloon inflated in the distal RCA on a second wire, and then with the help of it, use it as an anchor balloon in the main vessel and help us cross the second stent across the lesion. And then after the balloon dilatation, the pulling action on the balloon and the pushing action on the stent, we could finally place the stent in its position. So these are the 4 cases I want to show to you, and thank you for the time given to me.
Thank you, Dr. Rishi, for showing interesting cases. Actually, complex anatomy, you showed real complex things. I was actually wanting also to discuss something regarding multivessel disease in STEMI with some of this data. But it's very important to understand when you face such scenarios, such patients, especially in nights when people are alone, it's always good to call for help and try to do good to the patients. In times of problems, at least if you can give some flow with the form of POBA and get back these patients again for restudy, also patients do okay in times of emergency rather than just sending patients for surgery in the emergency. Many of the habit of sending patients for acute MI surgery, surgeons also won't like it. And that's why culprit vessel, at least POBA, giving some flow. If the human body is great, even if little flow is given, patient's hemodynamics improve. And again, they can get them back electively if you can't get help in the night. But somehow I have this feeling that acute MI surgeries, especially by the time surgeon arranges everything, it will be late, more than 6 hours, and the myocardium gets damaged. So whatever little flow you can give percutaneously, still patients do all right, though you may not get optimal flow. And as you showed in your cases, ectatic vessels, I think all of us are clear now that don't immediately stent it and try to recall them after 3-4 days of therapy and reassess, and they decide. Many of the times the flows gets established and thrombus gets dissolved. I think you've shown that, and also shown some interesting Lima anastomotic problems also, and highlighted the fibrotic nature of the grafts. I think you meant the left radial artery, I think, in that Lima.
Left radial artery.
Okay, right. I think thanks for showing a multivessel PCI. Now recently in the ACC they said full revasculature trial they presented showed that following FFR guided therapy for multivessels did not show benefit. Complete what it showed was beneficial. Here they said whether the culprit or FFR guided, there was no difference. Some reasons they mentioned. I think we should need to see in more detail. Before we conclude, Dr. Ajit sir, Thomas, anything you want to comment on this multivessel PCS or STEMI with complex anatomies?
We've gone full circle around with this culprit versus non-culprit. We started with doing culprit and not doing non-culprit. Then we said that do the culprit and then assess the non-culprit. That was the decision was whether that should be angiographic or should be functional based. And then the decision came that it should be functional based on the complete trial, which could be either done the next day or up to 45 days, and then stent it so that if it is significant, then that is true. And the third trial came, the flower trial, which showed that by doing FFR versus angiography, there was no difference, and in fact, the angiography turned out to be better. And then came now the trial saying that fix only the culprit. By doing functional test and fixing non-culprit, it doesn't help. So I think one thing is clear that you have to fix the culprit. As far as the rest, whether the non-culprit needs to be fixed or not, I think there's a lot of confusion as far as I'm concerned. My practical take would be unless the patient is critical non-culprit, which deserves treatment either at the time of the first procedure or at the time of discharge, it's better to leave these patients alone on medical management and follow them up rather than putting too many stents in these patients and getting into more trouble. This is my take, and I've been following this for some time, and I've been using functional testing a lot in the hospital for these areas. The other thing is functional testing is moving away from wire to non-wire based angiographic, QFR or VFR or whatever. But I think in general, functional testing is going down. If you look at this ACC, more and more less functional testing and more imaging is coming in. But I don't know whether it's still the final truth about non-culprit vessel is clear.
I think
I think
what we were following
just
before is that, sir, whichever we were thinking as very critical, we used to call them the pre-discharge and fix those vessels, and rest of the borderline things we were leaving. That's what I think individualization helps. And this latest trial, they said 40% of the patients in the other group were not done the treatment at all. So there could be some fallacies, but by and large, you said angiographic based FFR. The problem will be flows, sir. Again, if there is flow only, you can assess FFR values, QFR, whatever in the angiographic based also. But finally, your clinical judgment and the size of the vessel and the tightness, what matters in decision making, I think, or individually. Thomas, sir, you were telling something, so I'm sorry.
Yeah, I think regarding the functional, I think there was flower and then came the AMI frame study. Flower showed that using functional testing was not useful, that angiographic was the way to go. AMI frame came immediately after that, but between these two, the EAC guidelines came. If you look at the EAC guidelines, it says that go by angiographic rather than functional testing for the non-culprit vessel. That's the current EAC guidelines. But almost maybe about a month after that came the AMI frame study, which showed that functional testing was better when you do the non-culprit vessel. So I think it's a very confusing scenario. Understand that in ACS situation, functional testing may not be as useful as in chronic coronary syndrome, and therefore I think maybe we should still stay with imaging and angiographic decision making here rather than using functional testing.
I think complete two trial is being planned where one group is done only with image based, other group is only angio based. I think we'll wait for that results. And meanwhile, as Dr. Ajit sir said, what we are doing clinical practice, the other vessel, unless it is bigger vessel with critical stenosis avoid doing anything to that. That too, you can plan it pre-discharge rather than doing in the same sitting. That's what is the general thing we follow. Rishi, you want to say anything before we close?
I think it's perfectly well summed up, and this is I think Dr. Ajit's cases emphatically showed that we have to make a decision about, and we have to stop ourselves from using the reflex of stenting in all MI and use of imaging, finding out which is erosion, which is a rupture, which is a attenuated plaque, would help us great deal in doing less stenting and being more beneficial to our patients. Thank you.
Is there any increase in incidence of myocardial rupture after giving intracoronary thrombolysis?
I don't think so personally. See, the reason why intracoronary thrombolytic went out in the West was some early studies where there was BF when they gave intracoronary license. And that was shown as an SAE in many of the intracoronary thrombolytic trials. And that made people very wary of giving intracoronary lysis. The second thing is, do you get myocardial rupture? I don't think that makes any difference. We don't see more even with intravenous lysis. So there's no reason why intracoronary lysis should be there. I have to tell you, there's a major trial now coming with microvascular resistance. See, what we're doing with all these stenting or with imaging is epicardial vessels. But the big problem is microvascular resistance. If you do a perfect stenting, get a good epicardial lesion, and your IMR is low, when the myocardium is fired, or the IMR is more than 35, your left ventricle is not going to pick up. It's very difficult in an acute MI to do IMR studies, but there is now a study coming for microvascular resistance where they're using two arms, using a small dose of lytic before you put a stent, and no lytic and just a stent, and looking at IMR post both groups and checking where the microvascular resistance come down. And that study may show that, well, there's an indication that study, the initial pilot showed that giving lytic small dose before stenting may improve microvascular flow and improve the IMR and then get left ventricular function up, preventing microvascular no reflow.
Okay, I think we had very good discussion. Khan, any questions in the chat box, or how many people have logged in? You have any info? Anyway, we will see.
Sir, we have crossed around 850.
Okay.
Plus.
Okay. Thank you. Thank you very much. I think no questions. We have just overboard 10 minutes. That should be acceptable. Thank you again, Ajit sir and Thomas sir and Rishi for joining. And we wish more people would join for our Stemi India session at TCT India, and also request all of you to block your dates, July 26, 27, 28, HSCC Hyderabad, and make the program successful. We wish it will value for time, and request both of you also to be blocking time, sir. And Rishi, thanks for all the help, and do join for TCT.
Thank you,
Thank you very much again.
Thank you.
Thank you.
Thank you.